Hi, this is Peggy O'Connor again, and this is part 5 on bronchiolitis and the acute respiratory disorders in children pre-class assignment. The etiology of bronchiolitis is that it affects 30 per 1,000 infants who are under a year of age. There is an increased incidence of reactive airway disease and asthma later in life in these children, and it occurs between October through March or April, depending on the weather. Pathophysiologically, the respiratory syncytial virus, or RSV, is the most common agent that causes bronchiolitis. It is contracted by direct contact with secretions or indirect contact with contaminated surfaces. The virus is shed for 3 to 8 days, and the incubation period is 2 to 8 days. And what happens is the cell debris clogs the bronchioles, and that therefore causes the inflammation. Diagnosis is made by history and physical exam, chest x-rays, which will show patchy atelectasis, and confirmation and definitive diagnostic procedure is nasal wash or nasal swab for an ELISA test. I have put in URLs for 2 little YouTube clips. One is the one that you saw in the croup slides, and that's differentiating bronchiolitis and croup. And the second one is showing you wheezing and bronchiolitis. The signs and symptoms that you will see with bronchiolitis is the babies will develop a rhinitis, and it is clear, copious drainage. It comes out their nose, it goes down their throat, it's bubbling, it's really copious, and they're unable to control it. They then develop a cough, a low-grade fever, expiratory wheezing, retractions, nasal flaring, and even grunting. They will also show poor feeding, vomiting, diarrhea, dehydration. They will have increased irritability, and severe cases will demonstrate severe dyspnea, where the respiratory rate is greater than 70 breaths per minute. For medical treatment and prophylaxis, the medical treatment, these children need isolation when they're hospitalized. Two babies with the same diagnosis can be roomed together. Humidified oxygen to keep the O2 sats greater than 90%. They need hydration. Many times these children are not drinking when they're hospitalized, so they'll need IV fluids first, and then as they are getting better, they can start on PO fluids. Nasal suctioning. Chest physiotherapy is ineffective and should not be done. Hypertonic saline nebs or saline nebs are generally used. Albuterol nebulizers are no longer used because they're ineffective and they just cause tachycardia. CPAP can be used for moderate to severe cases. Those children are usually in the intensive care unit. And prophylaxis is generally with intramuscular palivizumab or Synagis immunizations, which are monthly. I have here a bronchiolitis scoring system. So there's a score, and you'd score a 0, a 1, a 2, or a 3 for each of respiratory rate, retractions, nasal flaring, wheezing, or general status. So if the respiratory rate is under 30 breaths per minute, that's a 0. 30 to 45 is a 1. 45 to 60 is a 2. And more than 60 is a 3. If there are no retractions, that's a 0. If it's only intercostal retractions, that's a 1. Intercostal, subcostal, or supraclavicular is a 2. And the abdominal seesaw respirations is a 3. For nasal flaring, if there's no nasal flaring, that's a 0. Mild and rare is a 1. Moderately severe and intermittent is a 2. Or severe and continuous is a 3. If there's no wheezing, that's a 0. If wheezing's heard only with the stethoscope, that's a 1. If it's heard on expiration with a stethoscope, that's a 2. And if it's heard on expiration without a stethoscope, that's a 3. For their general status, if they're acting as a normal baby should act, that's a 0. If they're moderately uneasy with an occasional cry, that's a 1. If they're very uneasy with a continuous cry, that's a 2. And if they're lethargic, that is scored as a 3. And then you would add up all the scores, and that would give you a score between 0 and 15. Nursing assessment, you're going to want to look at past medical history, looking for a history of chronic lung disease such as bronchopulmonary dysplasia or BPD, which you will cover that disease process in the high-risk newborn. Complicated congenital heart disease, which I will be covering under the cardiac, and an immunocompromised status. For birth history, find out if the baby was born prematurely, if there were multiple births, if they were born between April and September during those summer months, and if they are male. Next, you want to find out about the current medical history. These are usually babies under 2 years of age. There are more severe illness in a baby under 6 months of age. They are exposed to passive tobacco smoke. Are they living in crowded conditions? Do they go to daycare? Do they have school-age siblings? What is their socioeconomic status? Is it low? And is there a lack of breastfeeding? The next part of the nursing assessment is chief complaint, looking at signs and symptoms. These children will have clear, copious nasal drainage at the onset of the illness. They will develop pharyngitis and have a hoarse cry. They're low-grade fever. They will develop a cough 1 to 3 days into the illness and wheezing shortly after that, and the feeding will be poor. The next part of the physical exam is inspection and observation. So you want to look at the general appearance and color of the baby, looking for central and peripheral color changes. They might show some signs of air hunger, looking for various degrees of cyanosis and respiratory distress, tachypnea, retractions, any accessory muscle use, grunting. They may have periods of apnea, a cough. You may hear an audible wheeze on expiration, and they may be listless or uninterested in feeds, surroundings, or their parents. The next part, you're going to auscultate and note any adventitious breath sounds, determine the quality of the lung fields. If it's earlier in the illness, you may hear wheezes scattered throughout. In more serious cases, the chest may sound quiet and without wheeze, and that is because there's significant hyperexpansion and poor air exchange. So they are actually much more in danger of respiratory distress. Laboratory and diagnostic tests, pulse oximetry might be significantly decreased. A chest x-ray might reveal hyperinflation of the lungs and patchy atelectasis or infiltration. Blood gases might show carbon dioxide retention and hypoxemia. And the definitive diagnosis is a nasopharyngeal washing or swab, and that will identify respiratory syncytial virus or RSV via the ELISA, enzyme-linked immunosorbent assay, or IFA, immunofluorescent antibody study. For nursing management, our goal is to keep the airway patent. To do that, we're going to elevate the head of the bed to facilitate keeping the airway open. We want to do frequent assessment and suctioning of their respiratory status. You can use a Yankauer or tonsil tip suction in older infants and a nasal bulb suction in younger infants. We want to promote adequate gas exchange, so we want to monitor the work of breathing, the respiratory rate, and the oxygen saturation. Adjust the FiO2, which is the fraction of inspired oxygen or the percentage of oxygen, to maintain O2 sats above 93%. And elevate the head of the bed. To reduce risk for infection, institute and maintain droplet precautions. You can put 2 infants with RSV in the same room, and hand washing is imperative. We want to provide family education. Teach the family to recognize signs of the worsening condition and to call the healthcare practitioner if breathing is more rapid or more difficult, if they cannot feed or eat because of the tachypnea. If they're under a year of age, they are at higher risk, and coughing can persist for several days to weeks after the resolution of the disease, but they act well otherwise. And to prevent RSV disease is on the next slide. So RSV prevention, as I mentioned before, is by the palivizumab or Synagis immunizations, which is a monoclonal antibody given as a monthly IM injection to at-risk children who are under 2 years of age and were born prematurely and have chronic lung disease such as BPD requiring medication or oxygen, or 2 years of age and have certain congenital heart diseases, or 2 years of age and are in an immunocompromised state. This is the end of this section, and you just have the otitis media to complete. Thank you.